All right, let's get right into it. Welcome to this explainer, where we're going to absolutely master the high-yield pharmacology of the autonomic nervous system. I know, the sheer volume of receptors and drugs can feel completely overwhelming at first. But today, we're breaking it down logically. We're taking that giant mountain of data and turning it into a highly structured, super easy to digest roadmap tailored perfectly for your medical studies. Let's do this.
So, let's kick things off with a fundamental question. What exact system is pulling the strings behind your body's involuntary life-saving reactions? I mean, think about it. You don't consciously tell your heart to beat faster when a scary dog chases you down the street, right? And you definitely don't have to tell your stomach to secrete acid after eating a massive slice of pizza. Your body just handles it all behind the scenes.
To figure out how we can actually medically hack these involuntary responses, here is our roadmap for today. 1. The autonomic nervous system. 2. Sympathetic versus parasympathetic control. 3. Neurotransmitters and receptors. 4. The cholinergic system and drugs. 5. The adrenergic system and drugs. And finally, 6. Key clinical applications.
Okay, Section 1. The autonomic nervous system. Let's start by looking at the really big picture of visceral, involuntary control. This perfectly illustrates the physiological dichotomy that literally dictates human survival. On one side, we've got the sympathetic nervous system. That's your classic fight or flight response. Imagine a sudden emergency. This system instantly ramps up your heart rate, bronchodilates your lungs so you can get maximum oxygen, and dilates your pupils so you can clearly see any threats. Now on the flip side, the parasympathetic system is your rest and digest mode. It drops your heart rate, constricts those pupils, and ramps up gastric acid and peristalsis to actually process your food. They're basically the yin and yang of your physiological state.
Section 2. Sympathetic versus parasympathetic control. Now, to really understand the drugs, we first have to map out where these anatomical wires actually run in the body.
Check this out. The sympathetic nerves originate centrally in the thoracolumbar region, specifically from T1 down to L2. Now, they feature really short preganglionic nerves that quickly synapse. This setup allows for a massive, diffuse, full-body discharge during an emergency. It's like flipping a master switch for the whole house. On the other hand, the parasympathetic fibers take a craniosacral route. They use cranial nerves like 3, 7, 9, and especially 10, the mighty vagus nerve, along with sacral nerves S2 to S4. These guys have incredibly long preganglionic nerves that travel almost all the way to the target organ before they even synapse, which gives you very localized, specific control.
Okay, grab your highlighters because this is a massive high-yield fact for your exams. There's a vital structural difference regarding myelination that spans both systems. All preganglionic nerves are myelinated. They act like heavily insulated wires for super rapid initial signal conduction. In stark contrast, the postganglionic nerves, the ones directly touching and controlling the organs, are unmyelinated.
Section 3. Neurotransmitters and receptor types. Let's see how this anatomy actually translates into the chemical languages these nerves use to communicate, because this is where the pharmacology truly begins.
Right, so all sympathetic receptors at the end organ level are G-protein coupled receptors, or GPCRs. They don't just simply open a tiny channel, they set off an entire cascade of events inside the cell. We divide them broadly into alpha and beta families, depending on their secondary messenger system, whether they're GQ, which activates phospholipase C, GI, which actively inhibits adenylyl cyclase, or GS, which activates adenylyl cyclase to increase CAMP, they're going to either excite or inhibit the target tissue.
Now, what's really fascinating here is the stark contrast within the alpha family itself. Alpha-1 receptors are your classic excitatory GQ receptors. When they get stimulated, they cause smooth muscle contraction. We're talking intense vasoconstriction and active mydriasis, which is just a fancy term for pupil dilation. But then look at alpha-2. Alpha-2 is a GI type, meaning it is strictly inhibitory. It primarily acts as a presynaptic autoreceptor. So when norepinephrine builds up in the synapse, it hits these alpha-2 receptors, and they literally act like the brakes on a car, completely inhibiting any further release of that neurotransmitter. And then we have the beta receptors. Now, all of these are GS type, meaning they universally increase CMP. The absolute best way to remember their locations is a classic trick. Beta 1, well, you have one heart, so it increases heart rate and contractility. It's also chilling in the kidney for renin release. Beta 2, you have two lungs. It relaxes smooth muscle, causing bronchodilation, which makes beta 2 agonists, like salbutamol, absolutely perfect for treating an asthma attack. Finally, Beta-3 is found over in adipose tissue for lipolysis and down in the bladder where it relaxes the detrusor muscle so you don't accidentally urinate during an intense fight or flight scenario.
Section 4. Cholinergic system and drugs. Switching gears entirely, let's dive into the parasympathetic side of things, completely driven by acetylcholine and its muscarinic receptors.
Acetylcholine is the ultimate chemical of rest and digest. If you look at these two pathways side by side, you can see exactly how a classic anticholinergic drug like atropine goes in and chemically blocks this system. For example, atropine blocks the M2 receptors right on the heart's SA and AV nodes. Normally, M2 drops your heart rate, so if you block it, you successfully treat dangerous bradycardia. In the respiratory tract, atropine blocks M3 receptors. Since M3 usually causes mucus production and bronchoconstriction, blocking it totally dries up respiratory secretions. This is incredibly useful right before a patient goes into surgery.
The absolutely crucial point here is that you have to match the specific anticholinergic drug to your clinical scenario based entirely on its chemical properties. Take hyoscine, also known as scopolamine. It has fantastic entry into the brain, making it the undeniable drug of choice for motion sickness. Then there's benzexyl, used essentially to treat drug-induced Parkinsonism. But hey, what if you want to avoid those brain side effects entirely? That's exactly when you'd reach for glycopyrrolate. Because it's a quaternary amine, it physically cannot cross the blood-brain barrier. That makes it the preferred choice for drying secretions during surgery without causing any unwanted central nervous system toxicity.
Let's be real. We all love a good memory hook. If you need an easy way to remember the specific drugs used to calm an overactive bladder, just memorize the phrase, "off to school days." That stands for oxybutynin, flavoxate, physoterodidine, tolterodidine, sulfenacin, and daraphenacin. These are your vesicoselective M3 blockers. That means they specifically target and relax the bladder's detrusor muscle, bringing huge relief to patients dealing with urge urinary incontinence.
Section 5. Adrenergic system and drugs. Let's transition back over to the sympathomimetic drugs. These are the powerful agents that actively mimic our fight or flight response. So we have two totally different pharmacological strategies for ramping up the sympathetic system here. Directly acting drugs, like your standard catecholamines, bind straight to the alpha and beta receptors themselves. Boom, direct stimulation. But indirectly acting drugs, they don't even touch the receptor. Instead, they force the neuron to basically dump way more of its stored neurotransmitters, like norepinephrine and dopamine, directly into the synapse. Drugs like modafinil work exactly this way, which is why it's such a powerful treatment for narcolepsy. It forces the brain to stay awake. Zooming in on direct alpha-1 agonists, phenylephrine is your classic, textbook example. Because it directly contracts the radial muscles of the iris, it's the absolute drug of choice for dilating a patient's pupil for an adult fundoscopy. Why? Well, because it causes active mydriasis without cycloplegia. That means the patient doesn't temporarily lose their ability to focus their eyes. We also use midodrine, another alpha-1 agonist, to powerfully clamp down on blood vessels and treat postural hypotension. But a massive warning here. These are strictly contraindicated in glaucoma patients. Dilating that pupil can cause a super dangerous spike in intraocular pressure, and you definitely don't want that.
Section 6. Key clinical applications. All right, let's bring all this dense receptor theory straight into the emergency room and see where physiology meets actual patient care.
Understanding blood pressure control is incredibly nuanced. Your mean arterial pressure relies heavily on your diastolic blood pressure, which is driven by alpha-1 vasoconstriction out in the periphery. Now, what's crucial to grasp here is the concept of reflexes. If you push a powerful vasoconstrictor, that massive spike in blood pressure stimulates the baroreceptors in your neck. This immediately triggers a parasympathetic reflex that actively drops your heart rate. So you might push a sympathetic drug, but actually see reflex bradycardia. You always have to anticipate how the body is going to fight back against the drug you're giving.
And this perfectly illustrates how we can actually weaponize the body's own negative feedback loops. Look at centrally acting drugs like clonidine and dexmedetomidine. By stimulating those alpha-2 autoreceptors in the brain we talked about earlier, they literally trick the central nervous system into thinking, whoa, there's already way too much sympathetic activity going on. The brain's response? It paradoxically completely shuts down sympathetic discharge to the entire body. That's exactly why dexmedetomidine is such a fantastic, soothing sedative in the ICU. It actively lowers blood pressure, lowers heart rate, and provides deep sedation without causing respiratory depression. It's kind of brilliant.
Finally, we can't forget mixed-acting drugs. These guys both stimulate receptors directly and trigger neurotransmitter release indirectly, making them vital clinical tools. Ephedrine is the perfect example here. It is the absolute drug of choice for treating dangerous drops in blood pressure during pregnancy, especially during spinal anesthesia. Why? Because it highly effectively raises the mother's blood pressure while very carefully sparing the placental blood flow to the baby. Also, just a quick historical note, drugs like sibutramine and rimabant used to be anti-obesity drugs working on these pathways, but they're completely banned now due to high toxicity.
So after covering all these incredibly complex pathways, the crazy interplay of GPCRs and those powerful reflex arcs, you really have to wonder, how exactly do we manage this delicate balancing act? How can one targeted pharmacological molecule save a failing heart without throwing the entire rest of the body into complete chaos?
Well, the answer comes down to incredible receptor selectivity and deeply understanding exactly where these drugs cross over, like knowing which ones breach the blood-brain barrier. This explainer really proves that mastering the autonomic nervous system isn't just about rote memorization of random drug names. It's about fundamentally decoding the chemical wiring of human survival. So the next time you feel your own heart racing or your pupils dilating, ask yourself, is your nervous system actively saving your life, or is it just reacting to that massive coffee you chugged an hour ago? Keep tracing those physiological pathways, and thank you so much for joining me on this deep dive.